My name is Dr. Jeremy Theal, and I'm very pleased to be here today. I'd like to thank Canada Health Infoway and the Planning Committee for asking me to be here today and just share with you the story from North York General Hospital, which is not too far from here. And it's interesting hearing the discourse during the last panel and all of the conversation that was happening around the importance of engaging patients as partners and how digital health can be part of that. That's a really important piece of the puzzle, but what I'd like to show you now is I'd like to completely shift gears and talk about another very important way that digital health can transform the quality and the safety and the value of the care we provide. And what I'd like to talk to you about is really how these systems, when they reach a higher level, become partners in decision-making with the clinicians. Because if we were to imagine for a moment a world where we already had a perfectly engaged patient population, everyone was a partner with their caregivers. The other piece of that is that these patients are coming to us because they recognize us as experts, that we're going to give them an individualized decision which is going to be far better than what they're going to get off of Google or off some bite-sized consultation website. And so what's incumbent upon us as clinicians is to make that best decision. And the difficulty today is we have thousands and thousands of articles being published in the medical literature every single day. How are we as providers supposed to be able to get the best information individualized for each of our patients? And digital health is an extremely important and crucial tool in helping us make those better decisions. Not that the system is telling us what to do, but that it's a partner in providing better care. So that's what I'd like to talk to you about what we've been doing at North York and some of the tangible outcomes that we've been able to achieve to date. North York General is based in Northern Toronto. We're a medium-sized community teaching hospital with just over 400 acute care beds. And we have 3 sites, but I always show a picture of the general site because this is the only one that's pretty. The other ones are kind of dilapidated. So please just remember this one. This is the best one that we have of our hospital. So back in 2007, the senior team at North York General decided to embark on a program called eCare, which was to use electronic health information technology to transform the way that we provide care at North York General. And the reason why they decided to do that was because of all of the challenges that they recognized that we face. And I don't think this is unique to North York General or even to just hospitals. This is just everything that we're all facing. That we have studies like the Canadian Adverse Events Study in 2004 showing that we have thousands of preventable deaths happening in Canadian hospitals every single year, and that we need to do better for our patients. That it takes, on average, 17 years from the time something is first published in the medical literature to the time that it's regularly practiced at the patient's bedside, and certainly our patients expect much better than this and deserve it. We have an aging population, and we have fewer and fewer healthcare dollars to manage that population. And on the hospital side, we have many preventable complications, things like sepsis, VTE, and C. difficile that are in the press. Patients are aware of these issues, and we need to do better at preventing them. And so we embarked on the eCare project in 2007, and the goals of this project, first and foremost, were to use technology to improve the quality and safety of patient care. It's not just about making data available, such as lab results or medical imaging results. It's about using that data to make better decisions for better quality. We wanted to embrace a culture of evidence-based care. So at North York General, prior to eCare, the physicians, for example, were quite individualistic in the way that they practiced. They would each write their own orders for their patients, and they wouldn't necessarily have a lot of open dialogue about what might be the best way to treat their patients from an evidence point of view. And we wanted to change that culture. And we wanted this system to be a system that was built by clinicians and for clinicians, not something that's just bought off a shelf and sort of foisted upon the populace of the hospital, but rather something that we all designed together and that we had a shared vision of how that was going to look at the end of the day. The components of the eCare project include computerized provider order entry, including standardized evidence-based order sets which are based on conditions and symptoms. Closed-loop medication administration, which enables real-time check of medications given to a patient against physician orders to improve safety, and as well a number of other electronic medication management tools such as the EMR, medication reconciliation, and electronic discharge. very important to our community providers who are getting timely information on the time of discharge, if not before. And also advanced clinical decision support, that idea that I was mentioning that, that the system can become a partner in making better decisions. As part of the project, we knew that we had to create a large library of standardized order sets. Order sets are basically a collection of orders that would manage a specific condition that a patient would have when coming into hospital, such as pneumonia or a hip fracture or so forth. And we knew from the medical literature that if you standardize on evidence-based orders based on conditions, you can actually improve care. So that's what we wanted to do. We had a lot of heavy lifting to do with over 300 order sets necessary to cover all the main conditions that we treat in our hospital. And so we created a small, lean and mean team that was interprofessional, that had physicians, nurses, pharmacists, and clinical informaticists that would build the core library of order sets that we would use. And we based that on only on evidence. So we had a large volume of evidence, not only from evidence partners, but also other evidence that we gathered or had at our fingertips from existing protocols in our hospital. Now, it was very important that we didn't just take that information and just dump it in and allow people to use it. We needed them to be engaged and to take ownership of our system. So we then took all these order sets and went out and have all of our frontline physicians and clinicians review the content in these order sets and make sure that it was going to have the content that they needed and that they were happy with it. And that was really important for adoption. Very important for CPOE because there's lots of data to show that CPOE is something that typically is not adopted well, and in fact these projects can fail. This screenshot shows you an example of how our order sets were actually interprofessionally reviewed. We couldn't set an in-person meeting for every single order set because with 300 order sets to build, that would have taken 10 years. We're trying to get everyone's schedule together. So we had an asynchronous online review tool where physicians, nursing, allied health were able to simply go into their email, click on a link, and then open up the order set in their web browser. On the left-hand side, they can see the content of the order set, and on the right-hand side, there's a running blog-type commentary where everyone can see each other's comments and respond to them. So in this way, we were able to get a lot of our order sets reviewed and approved, and where there were particular areas of consternation or conflict where people couldn't come to a decision, we would then set an in-person meeting for those types of issues. The evidence is presented in the context of the workflow of the deciding provider, and this screenshot shows you how the evidence is actually right at the point of care, that when the physician or other prescriber is entering orders for that patient, the evidence is all visible face up inside the order set. And in fact, if you take one additional click, it then takes you to an evidence summary. And the really cool thing about this evidence is that it is granular. It's specific to the decision that is being made at that time. So rather than if you have a pneumonia patient with pneumonia, and you want to know which empiric antibiotic to use for that patient on admission, you don't want the evidence to take you to a general topic review of what are the symptoms of pneumonia or what is the epidemiology. You just want to know what is the evidence around what antibiotic to use. Otherwise, the evidence won't be used. So that's exactly what this does. It takes just what's pertinent to that decision, where those orders are in the order set, and shows you that evidence. And in fact, if you click on the blue links, one additional click, it takes you to the primary literature. So within 2 to 3 clicks, you're from the decision you were going to make right drilled down to the article that is based on that decision. Just prior to our go live, one of the things we wanted to do to really engage clinicians and ensure we got 100% adoption of this system was to win their hearts and minds. And so we created a marketing campaign where we recognized that physicians and other clinicians were going to have to be superheroes to make this huge change in the way that they practice. And so these 2 people are actually people from our hospital. We had a series of photos that were done. We had nurses, social workers, pharmacists, physicians who were posing as superheroes. And in fact, the person on the right there was our chief of medicine at the time. The one on the left was our chief nursing officer. So this sent a subliminal message to our clinicians. Hey, if our chief of medicine is willing to stand up in his underwear in front of us, he must really think this system is something to be proud of. So that was one of the messages. The other is that we attach the evidence to why these systems can make a difference for patients right inside the posters that we posted. So saving 21% of lives from pneumonia, that's based on a real article from the literature, a multi-center study. And so by doing that, we're really highlighting and grabbing clinicians on their intrinsic motivators as healthcare providers. This is why they're in healthcare, is to help patients. And so it takes the griping away from, oh, I can't find a computer to access the system, or maybe it's going to make me slower, and it gets it back to what the real issue is, which is how are we going to do better for our patients. So fast forwarding now, a couple of years later, I want to just talk to you about some of the outcomes from our system. It went live in 2010 in our medicine and surgery department, and we've been expanding since then. So 1 year post-go live, I should say even actually in the first week, we did have 100% adoption of the system by our clinicians, and this system was not mandatory. Physicians actually had the ability to pop off. If they felt that they were under duress and they couldn't look after their patients efficiently, they could actually go back to paper orders, but we found that they really didn't do that. They really did like the system. 92% of orders that were entered in the system were entered directly by physicians. So that means that the physicians were actually using the system. The other 8% were either verbal or telephone orders, and we would expect that there would always be a small proportion of that, but fortunately we weren't seeing that physicians were running off the nursing unit and then calling the nursing unit and asking the nurse to put in the orders. That wasn't happening. We had about 1.7 million orders entered in the first year, and that may sound like an impressive number, but I think what's more important is how many of those orders were actually initiated from evidence-based order sets. So we have that data. We did create over 350 evidence-based order sets, 42,000 activated in the first year, which meant that on average, somewhere between 2 and 3 order sets were being activated on every single patient going through our medicine and surgery program. Over 830,000 of those orders were from the evidence-based order sets, which meant that almost half of all the orders entered in the system by physicians were coming from those evidence-based order sets, showing that they really were embracing the concept of standardized care. One of the important benchmarks in the literature around taking care of patients who have sepsis in the hospital is how fast they get their first dose of antibiotic. We know that patients who get their first dose antibiotic faster tend to do better. And shamefully, I have to tell you that before our system went live, it took 291 minutes on average for our patient to get their first dose antibiotic, from the time that the physician first wrote the order on paper to the time that the medication was administered. But fortunately, after the system was put in place, because of all the instantaneous communication of orders that happens in an electronic system, we were able to get that down consistently under an hour to 50 minutes, which is an 83% improvement. Another important piece of our system was the closed-loop medication administration, where a nurse is using a wireless handheld device to scan barcoded medications against barcoded wristbands on patients and make sure that what they were administering to the patient is confirmed with the 5 rights, that it's the right dose, right time, right patient, right route, etc. And we found that through auditing, even in the first year, we were able to avert more than 2,300 medication administrations that would have been given to the wrong patient, because the system stopped the nurse and said, wait a minute, there's something wrong here. And obviously, it's in the heart of every healthcare provider never to make a mistake, but things happen. We're busy, it's chaotic, we're tired, and things happen. So the system is a partner in preventing those types of errors. Here's some outcomes looking at VTE prophylaxis, so the prevention of blood clots in hospital from immobility, very important benchmark for quality. It's one of the things that Accreditation Canada rates hospitals on. Prior to 2007, we had Bill Geertz, who's one of the leading researchers and one of the authors of the CHEST guidelines on VTE prophylaxis in hospitals. He was doing a study of all the different Toronto area hospitals, and unfortunately our medicine program was only at 17% of our medicine patients getting appropriate prophylaxis. We were all horrified, and then there was a education campaign put in place, including a paper order set, and we were able to get that number up to 65%. But as is often common with these types of blitzkrieg quality events, the change doesn't stick. So what happened was, we noticed a couple of years later, people were forgetting about VT prophylaxis, they were forgetting to use the paper order set, and our score dropped down to 50%. After we turned on eCare, because we had standardized order sets looking at how to treat how to give VT prophylaxis, we were able to get that up to 84% immediately. We didn't turn on any real-time clinical decision support at the beginning because we were afraid that physicians would see pop-ups and hate us. So we left that off. But the nice thing is it gave us a very nice window to then see what was the additional benefit of adding real-time clinical decision support. The idea that there would be an alert that if the physician forgot to order the VT prophylaxis in the order set, the system would remind them. And so when we turned on that alert, we were actually able to get up to 96% VT prophylaxis, and that number has been consistent for the past couple of years. Another important benchmark for quality in hospitals is medication reconciliation, and I think we heard Josh Tepper talk when he was talking about the journey of the patient and how they go through different pieces of the healthcare system and how medications get forgotten and don't get ordered. That's really important. So one of the things we did in our system was to try to correct that. Prior to eCare, we were using paper-based processes for medication reconciliation, and on average, in our medicine program, only about 7 to 9% of patients were getting medication reconciliation. After we turned on CPOE, because we designed a workflow for the physician where the discharge process includes discharge medication reconciliation, which immediately prints prescriptions for the patient and also fills in the discharge summary, that saves time for the physician and improves patient safety. And so we saw that even though we didn't make MedRec mandatory, we were able to get up to 70% on discharge and 45% on admission. When we looked at the workflow of physicians, we realized because there's a handover between the emergency consulting physician and the receiving physician the next day in hospital, that people were assuming that the other guy had done the MedRec on admission, and in fact nobody did it. So then we created a real-time alert to remind the physicians to do the admission MedRec, and we were able to get the admission MedRec also up to 70%. And at this point, fast forwarding to now, we're at about 85% on admission, 77% on discharge, once again this not being mandatory. The last piece I wanted to talk to you about in terms of outcomes is based on an article that was published not too long ago in Toronto Star, looking at preventable deaths in hospital and how we've been seeing some improvements. And so CIHI was noting that all the Toronto area hospitals were doing better in that department, but they noted that North York General was the top performer in all of the GTA, and in fact the second best in all of Canada. So our CEO, who was very kind, said that he thinks this is partially because we have built a really robust health information system in our hospital. But we didn't want to take his word for it. So we wanted to actually study the data and see, well, is it because of our system or was it something else entirely and we shouldn't be patting ourselves on the back? So what we did was we did a retrospective chart review, and we looked at all the patients who were admitted to our hospital and discharged with a diagnosis of either pneumonia or COPD exacerbation. And we looked at 2 time frames. We looked at before our CPOE system was put in place with a sample of about 520 patients, and then again after our CPOE system was put in place with a similar sample size. The groups were similar in age and gender distribution, and we applied the CIHI formula for probability of death, which corrects for comorbidities as well as diagnosis group, etc. We also corrected for critical care admission. Our primary hypothesis was that the use of CPOE compared to paper processes would result in a reduction in mortality in our patients and perhaps also length of stay and 30-day readmission rates. And our secondary hypothesis, and as far as we are aware, this is the first time this has been studied in the literature, is to actually do a deep dive and say, well, let's look at our data and say, what if the physician on admission to hospital actually picked an order set which matched the discharge diagnosis of the patient rather than just picking a random general order set? So if the patient had pneumonia and they used a pneumonia order set, that's a match. But if the patient had pneumonia and they chose an influenza order set or a general medical care order set, that wouldn't be a match. And does that affect mortality? So the results were that in our primary hypothesis, and I'll just fast forward down to the third line there, correcting our raw death rates for probability of death and critical care admission, we were able to see a 45% reduction in the risk of death in hospital from pneumonia with a p-value of 0.005, which is very strongly statistically significant, when using CPOE versus traditional paper processes. And in our secondary hypothesis, looking at whether or not if the physician chose a matching order set that had the evidence-based information to treat that patient's specific condition, again, correcting the raw death rate for probability of death and critical care admission, we saw a 56% reduction in the risk of death from that condition with a p-value of 0.024. And even more interestingly, if you chose an order set which didn't match the diagnosis, there was no effect on the mortality for the patient. Interestingly as well was the subgroup analysis, which here shows that there was a culture change in our hospital. We actually had a paper order set for pneumonia prior to embarking on our CPOE project. And that order set was used only 26% of the time for people who had pneumonia prior to embarking on CPOE. When we turned CPOE on, that number immediately went up to 60%, which is very interesting. Now, you would never expect this number to be 100% because you can't diagnose pneumonia perfectly 100% of the time. When someone comes in with shortness of breath, you might think they have congestive heart failure or they have COPD exacerbation, etc. So, but still, 60%, very impressive. COPD, we did not have a paper order set beforehand, but we did after with CPOE, and that went up to 45%. Also very interesting in the last row there, which showed what percentage of patients had any admission order set used. Prior to our CPOE project, only about 36% of our patients had any standardized order set used. So our physicians were not particularly interested in standardized care. But after eCare was turned on, 97% plus of our patients now have standardized evidence-based order sets used on admission. So in summary, the eCare clinical benefits we've been able to garner in the last few years include 100% clinician adoption, medication turnaround time improved by 83%, order set usage improved from 37% to over 97% of patients. Medication reconciliation improved from 8% to 80%. Improvement of our VTE appropriate prophylaxis rates from 50% to over 96%, which has been maintained. Mortality reduction in pneumonia and COPD patients by 45% using CPOE, and if the correct order set was used, an additional 56% reduction in mortality. So in closing, implementation of CPOE and advanced electronic medication management tools and evidence-based clinical decision support certainly can significantly improve patient outcomes, including mortality. And we felt that the keys to success included engaging frontline clinicians so that they would take ownership and adopt the system on their own and use it frequently, that we integrate the system into our clinical workflows, change the culture to recognize and embrace the importance of standardization and evidence-based care, have a robust system that is reliable to use, and that we continuously measure and learn and improve. So we showed you a couple of examples there where we realized, hey, we weren't getting the VTE rates that we wanted, or we're not getting the MedRec rates we wanted. What can we further adjust in the system through real-time clinical decision support to further adjust clinician behavior? And finally, just to mention that we've done lots of work in the CPOE space, and Canada Health Infoway has given us some funding to share the knowledge that we've been able to put together. So there is an online website, cpoe-toolkit.ca, which any other hospital that's embarking on computerized order entry is welcome to join. It's free of charge for any Canadian hospital. We have a 500-page implementation guide, which is going to be published shortly on that site. We also have a library of over 600 order sets, which are available for sharing, and different hospitals can actually share their content. So it's not just us putting our stuff up there, but other sites can also share. We have over 30 organizations and 300 users to date. And thank you very much. That's it.